Well, excuse me. Good afternoon, everybody. Thank you for joining us. I saw some individuals joining from all across the United States, even as far as Hawaii, I think. So that's fantastic. And Cassandra and I are thrilled to be here today and talk to you and share just a little bit of the resources from the American Heart Association around improving blood pressure control. A few of our objectives today, just to briefly share those from the beginning. We want to identify the evidence-based guidelines for self-measured blood pressure. We want to compare practice tools to design and implement an SMBP program. And we want to apply patient assessment and education tools for successful management of blood pressure. The American Heart Association's 2024 impact goal, which we'll be updating here before too long for the next set of years, but is to be a champions for health equity. And we think about advancing cardiovascular health for all, identifying and removing those barriers to healthcare access and quality. That really gets at the heart of what we're trying to achieve through our work on self-measured blood pressure and hypertension control overall. And you'll see in particular at the bottom there, we call out the social determinants of health, structural racism, and rural health inequities. And we know that you all play an important and critical role in helping to achieve those same goals around addressing health disparities. So thank you in advance for the work that you do already. So when we think about rural America, and certainly many of you are serving workers and residents in and across rural United States, we look at the mortality disparities that exist, unfortunately, between rural and urban areas. And we see from this chart that for many years, the mortality rate was approximately equal, but a gap started to emerge in the early 1990s when urban communities experienced greater success in reducing mortality. And we saw that gap widen until about 2016. If the chart continued, you would have seen it narrow just a little bit for a couple of years. And then with the onset and in the aftermath of the COVID pandemic, we've unfortunately seen that gap widen a little bit further. So the American Heart Association recognized this as a challenge, as a problem and a challenge to be met. And so in February of 2020, we released our presidential advisory, a call to action on rural health, which was really about collating the data that was out there and the evidence that is there around rural health disparities, and then charting a path forward for the Heart Association and our stakeholder partners to really systematically and comprehensively address those disparities and move forward with a plan to improve rural health in particular. So a few more statistics for you and just kind of an overview of some of the challenges facing rural communities. And some of you might well be familiar with a number of these factors. But we see again that 3-year life expectancy gap, much of that attributable at the end of the day to heart disease and stroke. But we see the factors that go into that rural women face higher maternal mortality rates, that residents generally have higher rates of tobacco use and physical inactivity, that there's challenges accessing mental and behavioral health care, as well as primary care and emergency care as well. And really a lot of the challenges do come down to that question of access, whether it's accessing healthcare, healthy grocery options, opportunities for physical activity. And the AHA is working to address those challenges around access and meeting people where they are. So we do have our Target BP program that you'll be hearing about and seeing referenced on the slides throughout today's presentation. And so it's our overarching comprehensive effort to address hypertension. And so you'll see many of the resources from the presentation today are found on the Target BP website. So Target BP has at its core the MAP framework for addressing hypertension, and it came out of a study at Johns Hopkins University that said if we want to control hypertension better, we need to do 3 things, and we'll get to that in just a second, what each of those components the MAP stands for. But before we do that, we have our first poll question of the day. to really set the stage for today's conversation. What stage of development is your organization's SMBP program in? And you see some of the options there. We do not have an SMBP program and are not considering starting one. We would like to have an SMBP program, but aren't sure where to start. Actively planning for an SMBP program. We have a small pilot program. We are scaling our program up to reach more patients. We have a fully functioning SMBP program and are already evaluating results, or unsure. If you can take a second to go ahead and vote in the poll, that would be great. All right, so we see a good mix here of stages of development. A number of folks would like to have an SMBP program, but aren't sure how to start one. We see another handful that are actively planning to start their program. Some others that have a small pilot program. So really it's across the board here. And hopefully everybody can feel a little bit more confident in their either starting or enhancing an SMBP effort by the time today's presentation is over. Thank you to those who voted. So the first part of controlling hypertension is really focused on measuring blood pressure accurately. We know that you can't move forward in terms of diagnosis of hypertension. We're going to go back here just a second. Sorry about that. This is an overview of that entire MAP framework that says if we're going to control hypertension, we need to measure blood pressure accurately every time to obtain those accurate representative readings and reduce clinical uncertainty. We need to act rapidly to diagnose and treat hypertension and reduce therapeutic inertia. And then we need to partner with patients to activate them in self-management, self-monitoring, and promoting adherence to treatment. And you can see that when all three of those intersect, we achieve higher rates of hypertension control. And so we'll start today with accurate measurement of blood pressure. Data suggests that only about 10% of clinical blood pressure readings are done according to the guidelines. And so there's a lot of opportunity in almost every organization to find improvement. And that brings us to our second poll question. How often are your staff trained in proper blood pressure technique? You should see another poll popping up here in just a second. Are they trained only upon hire during new employee orientation? Every 6 to 12 months? Every 2 years? Every 5 years? Or unsure? Now the poll is alive for everybody. Give you just a second on that. All right, how's it looking, Sylvia? Let's see what the response was today. Okay, so we see a number of people marked those who knew generally said about every 6 to 12 months with a few exceptions, but a good degree of uncertainty in the question as well. And so hopefully this can be an opportunity coming out of this conversation today to find that out for your organization and see what resources might be needed to help move that forward. We'll give you the answer as to what should be happening here in just a second. So there are a number of factors. We'll use an analogy here that one of our colleagues started to use, and we've kind of run with it. When we think about getting somewhere in a car, there are a number of things that influence the safety of a journey. We want to make sure the vehicle itself is operating in a safe manner and has all its mechanical components working. We want to make sure a driver is functioning with the proper training and avoiding distractions. And then we want to make sure that the road infrastructure is safe and secure, that it's not full of potholes and other road hazards. In a lot of ways, it's very similar when we're thinking about the accurate measurement of blood pressure. We want to make sure that the devices that are being used are there for, are are calibrated and validated for accuracy. We want to make sure that the team is trained to use proper technique. And then we want to look at that care environment and process as a whole. We'll share just a little bit about that now. So when we think about accurate equipment or that safe vehicle example, are the monitors being used by your clinic? And this would apply to both self-measured monitors for home use as well as those being used in the clinic. Are they validated for clinical accuracy? The US Blood Pressure Validated Device Listing, or VDL, is a relatively new resource, I think about 1.5 years old now, that offers third-party evaluation of monitors for accuracy. And we're really encouraging clinics to review their devices against that and prioritize securing devices from that list or these other ones from Canada and the England and Europe to ensure better clinical accuracy. And then once we have that accurate device to start with, we want to look at calibration of the devices. And some of the considerations to think about are how often does a device need to be calibrated? The evidence is pretty clear that automated monitors are generally more accurate for a variety of reasons. But one of the reasons it's also worth the investment a lot of times to go for those automated monitors is because they do require much less frequent calibration of devices to maintain that peak accuracy. I will also mention that the links here, when you receive the slides, will all be hyperlinked to the actual resource. Many of the graphics are as well, so you can use this slide deck as a kind of a glossary or an index to access further information as we go. When we think about training and technique, is your team prepared? And those of you that are training staff every 6 to 12 months on accurate blood pressure technique, that's exactly what the evidence suggests. You see a number of the errors here that often emerge during blood pressure measurement in a variety of clinical settings. We see crossed legs, cuff over clothing, full bladder, talking or active listening. These are not necessarily cumulative, but any one of these errors introduced to the clinical setting can introduce that idea of clinical uncertainty and leave the provider unsure of what to do next. And is the patient actually hypertensive, and should we prescribe medication? And so getting that accurate measurement is really foundational for the effort. After the training, and we have a variety of tools that are out there to help facilitate that training for your organization, depending on the needs of your organization and kind of the structure. Do you do group trainings or individual trainings? We also recommend using an objective assessment of those skills. And we have one example linked here that some organizations have chosen to do from a supervisor to staff model, but many others are using kind of a peer-to-peer model to help observe and make sure that the training has had the impact it should on actual implementation of blood pressure measurement. And then the last thing you'll see on this slide is our purple blood pressure positioning graphic. We're encouraging organizations to place these wherever blood pressures are being taken. It's a nice visual cue of those common errors and can help the staff be refamiliarized with the proper technique. But we've also had conversations and seen the example of it helps the patient themselves know what to do. It can actually improve the efficiency in the exam room because the patient already has their sleeve rolled up, hopefully, has put their cell phone away, etc. And those are available for download from our website in a variety of sizes and in English and in Spanish. Moving from accurate measurement, we want to make sure we act rapidly to maximize the opportunity of clinical systems on achieving blood pressure control. And that brings us to our last full question for today. So what single factor is the most impactful on achieving blood pressure control? Improving patient medication adherence, shortening the time between office visits, intensifying treatment by adding a medication class. If you were really paying attention, you might have seen some of the answers flash there for just a second, but we'll see what people's knowledge base is on this one. This is definitely the hardest question on the slideshow today. All right, what have we got for an answer? So we saw a lot of improving patient medication adherence, good number on shortening the time between office visits. And then a few of you either knew this ahead of time or did catch the answer as it flashed up about intensifying treatment. So kudos to those 4 individuals. You can see the relative impact on US blood pressure control rate from the study that was done, that if we assumed a 45% control rate on average, if we improved patient adherence to 100%, we would get about an 11% growth in control rates. Shortening that return interval to every single week would increase blood pressure control rates another 10 or so percent. But if we intensified treatment appropriately in even 62% of patients, we would achieve a blood pressure control rate of greater than or equal to 80%. And so certainly those first 2 things are strategies worth exploring and things to encourage when possible. But treatment intensification represents a massive opportunity in many cases to improve blood pressure control rates. So we look at a few key drivers of blood pressure control is really looking at what other gaps are there between science and practice. How can we improve blood pressure control and reduce some of those disparities that rural residents face as a whole, and then individual or more general, more specific demographics within rural communities face even more so. We want to look at treatment intensification with a new class of blood pressure medication. Currently, that only occurs in about 12% of visits for patients with uncontrolled blood pressure. And then fixed dose combination medications, which can help simplify the process for patients and improve patient adherence, as well as reduce costs, are currently only prescribed to about 25% of patients. So a few specific examples of how organizations can think about acting rapidly in a more efficient way and improving blood pressure control. And a couple of those ideas are pulled out here on this slide as well. Really encouraging the use of single pill combination medications, adopting a treatment protocol that shows a standard of process for throughout your organization of if blood pressure is this, then what is our next step as an entity? Also looking at, really operationalizing this process across the entire care team, involving the pharmacists in that conversation. Are there community health workers who can help remind patients about their medication? It'll look different in every organization, but the more people that have rallied around the idea that hypertension is a critical factor for patient health and performance measures at the organization, the more successful you're generally going to be. Now that brings us to our last of the MAP framework acronym, and that is partnering with patients. SMBP is part of that, and Kassandra is going to go through that here in a minute, but just a few other quick ideas for you all. We really want to engage patients in evidence-based collaborative communication strategies such as Teachback, and there are resources on Teachback and motivational interviewing on our Target BP website. We're going to talk about SMBP here. We're going to look at resources to support medication adherence and promote adoption of healthy habits and lifestyle changes. So a few things, and one of the exciting things about hypertension control, I think, is that there are a number of doorways that patients can walk through to help improve their blood pressure. Certainly medication plays an important role in that, and we talked about that, but engaging the patients in opportunities to modify their own lifestyle choices can certainly help. And so looking at weight reduction and the DASH eating plan and restricting sodium intake, each of these can have a proportional reduction, an approximate reduction of systolic blood pressure. And I don't have the data in front of me, but I think it's about a 5-point drop in systolic blood pressure can equate to about a 9 to 10% reduction in heart disease and stroke risk. So a significant impact. As a side note, one of the things we encourage is utilization of the ASCVD risk calculator to help really formulate that risk reduction for a patient as their numbers shift and their habits change. The Heart Association does have a few resources out there that can certainly help with this conversation and provide resources for patients. Our Healthy for Good has these infographics on eating healthy, exercise, mindfulness. There's some on tobacco control in both English and Spanish. And so those are complimentary and downloadable from the website. And again, they will be linked here when you receive the slide. Also, just wanted to call out the guidelines on the primary prevention of cardiovascular disease, that adults should engage in at least 150 minutes per week of accumulated moderate intensity physical activity, or 75 minutes of more vigorous intensity physical activity. We do have on the Target BP website, one of the initiatives within Target BP is periodic webinars that really dive into some of these details. Many of them do focus on the actual kind of clinical management of hypertension, but we've also got some out there on physical activity as it relates to hypertension, nutrition as it relates to hypertension. So I would encourage you to visit the website potentially and check out some of those recordings of past webinars. And with that, I will stop talking and turn it over to Cassie to talk about SMBP.
Thank you so much, Tim. So Tim gave us a really great overview of the MAP framework, and many of you may be familiar with it and may have seen some of this content previously. So hopefully it's either a good review or you do learn something new today. And a really important piece of that MAP framework and managing hypertension is the use of self-measured blood pressure monitoring. And so let's see here. There we go. So in 2020, again, another publication, a policy statement that was released jointly with the American Heart Association and the American Medical Association was this statement on self-measured blood pressure monitoring at home. If you have not had a chance to take a look at that publication, I would highly encourage it. There are a lot of good points, and it expands on basically everything that we are talking about today. So some of the highlights there, of course, are improving the accuracy of diagnosing hypertension. I think many, if not all of you, are very familiar with white coat hypertension, but also the flip side of that is, of course, the masked hypertension. And we may not really hear as many, we may not hear that as often, but I actually just recently was speaking with a health center who identified a patient who had masked hypertension. Their readings at home were much higher. And so this is really important, especially when we talk about medication intensification and taking all of these actions to improve our patients' blood pressures. We want to make sure that we're acting appropriately based on accurate readings. So this is another way. The utilization of SMBP, of course, is a way that we can really ensure that our patients, that we are treating and acting appropriately based on accurate measurements of our patient's blood pressure. And then, of course, as I just talked about, titrating those medications in conjunction with either telehealth counseling or in clinic interventions, and then using in between clinic visits, office visits to determine if blood pressure is being controlled or not, and being able to manage that remotely is very helpful and a great use of SMBP. And then helping patients adhere to treatment in that P framework, in the MAP framework, the P piece of that, of partnering with patients. Patients who engage in SMBP may be more likely to take action, and again, it's pulled out of that statement, but when patients can see the effects that their lifestyle changes and their medications have on their blood pressure, it can help them really understand and be more likely to stick with those changes, whether it be medication, diet, exercise, all of those things. So how do we maximize the impact of SMBP? And you'll kind of see here the common acts or kind of ways of thinking, and really what's recommended and what the guidelines recommend to use. So starting with the purpose, to use SMBP is to really inform that diagnosis, that accurate diagnosis, and then the appropriate treatments. Your health center, healthcare champion, can vary, but really if, utilizing and designating somebody to be that QI champion, regardless of what model you might use for quality improvement, whether it's a PDSA or some other type of process improvement, really continually reevaluating your program, your SMBP, and utilizing that, changing that workflow appropriately. Again, utilizing the data to inform the diagnosis and treatment. Really focusing into, sometimes we've seen the tendency to just distribute blood pressure cuffs to whomever, but really what we would like to focus in on is the three indications for utilizing self-measured blood pressure monitoring, which is those patients with elevated blood pressure to confirm the diagnosis, patients with hypertension that's not yet at goal, and then patients who are focused on med adherence and or lifestyle change. And so within that elevated BP, of course, we talk about the use of that SMBP to identify white coat hypertension, or masked hypertension. And then, of course, focusing on those patients with uncontrolled hypertension. The frequency of measurement, really, again, guidelines indicate 2 times in the morning, 2 times in the evening for at least 3 to 7 days prior to their next visit. If they're being assigned or if they're being entered into your SMBP program during an office visit, then they should be utilizing it for at least a week. Really, 3 to 7 days is going to get you the best, most accurate readings and most accurate data to be able to confirm a diagnosis. And then the duration, again, we're going to talk about the duration a little bit more, so I'm not going to dive into it right here, but I'm going to talk about it a little bit later about the duration and how you might want to determine how long a patient should keep and be enrolled in that program. And again, depending, you'll also want to, this is part of the protocols, the treatment protocols that Tim touched on a little bit, really standardizing your follow-up appointments with these patients. So is it every 2 to 4, is it every 2 weeks? Is it 4 weeks? Is it based on what you're trying to determine? Is it based on their control rates? Are you checking in on a weekly basis? But really standardizing that across all of the patients who are enrolled in your SMBP program can really help to maximize that program and ensure that you're getting the results that you want for your patients. And again, we really want to be consistent with the scientific evidence and AHA and AMA guidelines so that we can really support that blood pressure control. So as I said, I would dive into this a little bit more. So a common question, a very frequently asked question is how long? If you're doing a loaner device program rather than just giving the devices outright, which can be a lot more manageable to do a loaner program if you have a limited number of cuffs. This may be able to help you reach the most patients. So the duration of device use is really going to depend on your treatment goals for your patient. Are you actively making medication changes? Are they actively making lifestyle changes? Or is this more of an ongoing management type of thing? Ultimately, though, ideally, evidence-based guidelines is to have those 2 readings in the morning, 2 readings in the evening. So again, the morning readings should be taken before medications, and they should be 1 minute apart. The 2 in the evening should be just before bed, 1 minute apart, times 3 to 7 days. Ideally, consecutive days, not skipping a day, and that will give you 12 to 28 readings. And so then you would average those results. We have an average calculator that can be very helpful whenever you get those results back. We have an Excel document that can help you quickly average those results and utilize those data to make your determinations. And so again, depending on, this can be a starting point of 3 to 7 days if you're really just looking to confirm a diagnosis. But then whenever you move into that treatment intensification phase, or making other adjustments, you may want to extend that to 2 to 4 weeks, or even longer, depending on some of those changes that may take a little bit longer, like those lifestyle changes and healthy eating changes and reduction in sodium intake. During ongoing management, again, maybe even longer. We've had some with 3 to 6 months of time that they keep a patient in the program, in their SMBP program, for monitoring with ongoing regular checks in between. And that's really that key piece, is making sure that the measurements continue and that patients are continuing to monitor their blood pressure Again, as Tim mentioned, our colleague, who's our target BP program manager, another one of the things that she likes to say is blood pressure cuffs don't fix blood pressure. It's really, what are we doing? How are we helping the patients and utilizing those data that are going to move the mark? A big piece of this, again, is preparing patients for success and helping them understand why they are being chosen for this program, why they need to consistently measure their blood pressure and consistently communicate these results back. And so we have this self-measured blood pressure patient training checklist that can help you or your staff or whoever is going to be entering this patient into the SMBP program. It also talks about there's also a guide there to help you measure the patient's arm and get them the correct cuff size, which on that chart that Tim highlighted we know that the wrong cuff size can greatly impact the blood pressure readings as well. That this is this graphic that you see here, the how to measure your blood pressure at home graphic, is that complement to the purple graphic that can be posted in office. You can include this, you can include a link to it, however you choose to do that for your patients as a reminder whenever they're at home, all of those things to do that are just as important to do at home to get accurate blood pressure measurements. And then I really love these patient training videos. They're about 4 minutes in length. It's available in English and in Spanish. I really love these videos as a very simple way to teach your patients how to perform SMBP. It can be a great teaching tool whenever you're enrolling a patient. Pull the video up, have them watch it, step out of the room, or continue charting while they watch the video, turn around, ask them, okay, now tell me what you just learned. What questions do you have for me? How can I help you now? So it really standardizes the treatment or the teaching, standardizes the teaching for every patient to ensure they're getting the same information every time on how they are to perform SMBP whenever they go home. And again, all of these links are included. They'll be included in the slides that we send and follow up. Another, on that note of the right cuff size, a common question that we get asked as well are these wrist cuff devices that are now available. There are now some wrist cuffs that are on that validated device listing that Tim mentioned up top. And so, but there are cautions and there are considerations to be taken if you choose to use wrist devices at home. This graphic is great. It really summarizes it and shows you exactly how this should be done. So while they are more convenient, it is very important to, again, we don't want to counteract the benefits of SMBP by having inaccurate measurements with these devices. So we just want to be very careful and ensure that patients really are taught well the proper positioning for the use of wrist devices, wrist monitors, and really make sure that that will be followed for these validated device per the recommendations that make them able to be on that validated device listing. Again, link here to that scientific statement and to this resource. So let's get into a little bit of the program planning and technology. Love this device, resource with the Million Hearts. There are many resources on the Million Hearts through the National Association of Community Health Centers and on the Million Hearts website as well. But this implementation toolkit is very comprehensive, includes a lot of the information and the frequently asked questions that I get. I refer back to this often. And it also includes lots of links to resources from other health centers who have implemented SMBP, and it gives you exactly, there's protocols in there. I'm a big fan of not reinventing the wheel. If there already exists a resource that somebody has created, a protocol, procedures, anything like that, a patient education resource, I'm a big fan of reusing that resource that's already been created for you. We know your time is valuable. You don't need to spend more time recreating something that somebody already has. So there are lots of links in this resource to other things that have been created and been successfully used, other best practices. So highly encourage you, if you're looking at scaling or just getting started, or really anywhere along the way, would really encourage you to look at some of those resources that are included in this implementation toolkit. So lots of device management. And so some of the device management considerations are, again, that device selection. It's just as important to accurately measuring your blood pressure as positioning is. Decide if you're going to do a loaner program or if you're going to distribute the cuffs outright, or you can do a hybrid. Many health centers choose to do a hybrid. The distribution method, who's going to be responsible for that, how many devices are you starting out with, and what's really manageable for your health center as well. Cuff sizes are very important whenever you're ordering and considering cost with those larger cuff sizes, and some devices don't have all of the sizes on there available, and either on the validated device listing or just in general. And I'll talk about that a little bit more here coming up. Determine how long patients are going to be using this, the return process, storage, tracking, and cleaning. So all of these are included. Really determining also your staffing roles, so coordination, training. We saw that most of you are doing that 6 to 12 month training interval, which is perfect. We really, encourage right in that interval, either once or twice a year, to get that training. And then who's going to be training the patients on that as well? Device management, your clinical champion. We talked about that QI champion and who's really going to be monitoring the success of this program. Outreaching to those patients and ensuring that there's a way to track who's in the program and that they are getting regular follow-ups. And then the data management, of course. And then identification of appropriate patients. We've talked about that, so I'm not going to dive into that a whole lot again here, but we've talked about what patients are eligible, who do you want to capture with SMBP, and then the recommending to the patient and the training of the patient. A little bit on the technology side, of course, some of these devices are enabled with Bluetooth, and so you are able to directly, or I guess it's through a third party really, is how you're able to get this data into your EHR. It's really up to you if you decide to go that way. It also may be dependent on your patient's capabilities. How tech savvy are they? There are apps. There are these, like it mentions here, device apps, RPM, portals, etc., that can help translate this data or transfer the data directly into your EHR. But you really want to decide what's going to be best for you. And again, ensuring that the device is on that validated device listing. There's lots of, again, degrees of integration. Sometimes simpler is better. Sometimes this high-tech option is not feasible for everybody, depending on connectivity, especially when we talk about rural locations, when we talk about rural health. Wi-Fi is not always available everywhere, or reliable connection is not always available. This may not be a viable option. And so then we have that patient blood pressure log where they can just manually keep track of these. This device comparison is really great. It's extensive. Look for it to be updated though as well, but this kit is a good starting point if you're trying to decide what devices to use. Again, it's very personal. It's personal for you and your health center, what your needs are and what your price range is as well. So take a look at this. It's linked here on the slide so that you can, it has lots of the different device features up here across the top. And then of course the brand name and the cuff name are here included. It gives you the size ranges that are available for each of those devices, and so that you can decide which ones are best for you. Some considerations: data privacy and security. If you are looking to do that direct connection, just keep in mind federal, state, institutional policies. If you're using a device or third party, review patient privacy notices and determine what might be needed. And of course, every situation is different. We are not giving legal advice here. Something that may need to be considered if you go that route. I'm going to touch briefly on your SMBP. On the Medicare and Medicaid coverage and reimbursement. So under Medicare, the SMBP services are reimbursed, but the devices are not covered. We did submit a request for this. So continuing to work on that. AHA and AMA are continuously active. And of course, I'm located in the state of Texas, and so we are currently in session right now. Our advocacy teams are working very hard at the state level to expand and ensure that there's coverage for the devices, and that the coverage for services continues. Under Medicaid, this is a great resource. You can look by state. It breaks it out by every state and what is covered by these 2 CPT codes. And so it would encourage you to take a look at these if you're unfamiliar. Talks about SMBP specifically, but also goes into your BP, your blood pressure device codes as well, under the DME fee schedule here. So if you are unsure or just interested to see where your state lines up with others, I would encourage you to take a look at this. Ultimately, the total states with coverage, there are 22 states under the 473, and then 19 states under the 474 who do provide Medicaid coverage. I'm coming up on time here, so I'm going to just kind of quickly go through this. But in your SMBP process, this was a great source from the Colorado Department of Public Health. And so it talks about, again, breaks out your SMBP specific codes and then your RPM CPT codes. And so you can kind of look at the 2 different things, and they've broken it out of which steps that the billing relates to here on your SMBP process. So I encourage you to take a look at this just as an example and kind of see how this might help you understand how that billing and reimbursement might align in your own program in your state. And then again, these CPT codes, the 99473, 99474, this talks about what exactly each of those codes are used for. And this is a source from the National Association of Community Health Centers that can be helpful for you. Again, just talking, just kind of reviewing the implementation phases. So you've got your planning. We've talked about those documents that we have. Look at your program goals. Of course, we're all aiming to reduce hypertension rates and helping our patients understand that how their blood pressure is affected by the things that we're doing and the treatment plans that we provide for them. Prepare for it. If that means creating a new policy and procedure, we really want to look at standardizing care across the board, especially if you've got multiple providers in your practice. Some that are single provider practices, maybe a little bit more consistent because it's one person, but if you've got multiple providers, we really want to ensure that this is consistent across the board and every patient who's enrolled in SMBP gets the same thing, that staff training, acquiring the equipment, and integrating your technology. If you want to start with piloting, identifying a smaller group of patients that might be more manageable for you, especially starting out, testing it, like I said, looking at those QI processes, adjusting your program as needed, and then making those adjustments moving forward to ensure that everything is working smoothly. I don't think I've worked with a single health center who has designed a program and then just run with it and not made any changes. There's almost always some adjustment, even if it's minor, whether it be in the patient training, whether it be in how they get the devices back, how they get the data results back. So there's going to be some changes there. And if it's helpful to start with a smaller cohort, absolutely, let's do that first and do work on those small tests of change. And then, of course, scaling it, expanding it to more and more patients and expanding your patient recruitment. Your motivational interviewing can be a really great part of this and identifying which patients to start with and then which patients to scale to of who's really going to be actively involved in this, and then continuously evaluating. And really, this is circular more than anything. You're going to continue evaluating not only your patients, but the program, and then continuing to adjust from there. And then I'm going to let Tim speak about this just briefly. About this specific community, specific community health center and their program.
Perfect, thanks, Cassie. So just an example of how this can all come together for your health center or clinic. North Lakes Community Health Clinic has 7 locations across far northern Wisconsin, very rural area. And as we went through some of these conversations with the team there, they realized there was a need for annual staff training on blood pressure measurement accuracy. And so we helped leverage some of the tools within Target BP to do that. In that case, they had a pretty robust SMBP program already, but we provided a few tweaks to it and then helped them elevate that success amongst other health centers. We have just recently started doing some work to consider the role of social determinants of health, and we're exploring some opportunities through our Doctors with Heart program that allows remote consultations for their primary care staff with volunteer cardiologists. And at the end of the day, you see that North Lakes credits these activities with increasing their accuracy and confidence in their blood pressure measurements. And so that's the exciting thing we try to do, and certainly the opportunity we want to make available to all of you, and I'll let Cassie bring it home from there.
Thanks, Tim. So again, just kind of an overview of the resources that we have. We have this compilation quick start guide. So it includes that MAP framework and SMBP. So it's everything that Tim talked about and everything that I've been talking about, and combines the two into one quick start guide. Within what I love about this guide is that there are links, direct links from the guide to everything that is mentioned and everything that is needed. So if you want a resource for something, the links are right there embedded in this guide. So please take a look at that. It includes the pre-assessment tool. It includes our Enduring CME CE courses. Take a look at those as well. We have several that are offered free of charge. There's one with an associated cost, but many of them are free of charge, and they do offer not only CEUs, but as well as CMEs for your physicians and providers as well. Also includes many of these QI and practice tools that I mentioned when your quality improvement as you're building and improving your programs, and lots of patient education resources as well. And so wanted to focus on the fact that we don't just work in blood pressure, we also work in cholesterol and type 2 diabetes. We know that these three things go hand in hand whenever we're talking about management of chronic diseases. And so we work in this ambulatory quality space, not just with Target BP, but also with our other two quality improvement programs. We would highly encourage you to take a look at these other two. There are free resources directed towards both providers and patients. We try to connect clinical partners to others around the country who are engaged in the same work. And I see some questions in the chat already. And we love working to connect people either within your same state or across the country who may be in similar sized institutions or clinics or health centers. And so we also offer recognition opportunities for these for all of you who are continuously working, following the evidence-based guidelines and working to improve your patients' control rates, whether it be with blood pressure, cholesterol, or type 2 diabetes. And so our registration platform is open. Just a really quick shameless plug of our recognition program, recognition platform that is open right now through May to be able to submit your data and get recognized for all of your efforts. We know that you're all working really hard on this. We know that it's something you wouldn't be here if it wasn't important to you. So want to provide that resource for you. And again, that's linked right on the slides. And then just again, Tim touched on this of joining Target BP, and we've talked a lot about all of the resources that are available. There's even more. You get more specialized one-on-one help with a local CI, local community impact, or American Heart Association staff member or American Medical Association staff member who can really help work with you one-on-one. And again, it's all offered free of charge. There's no catch. We just want to help you help your patients. Next steps, go register your health center. Sign up for one or all of these programs if you want. Look at the MAP Quick Start guides. We asked you, how often are you conducting training? Are you using these validated devices? Are you using a treatment algorithm, and when was it last updated? And so then go and evaluate to see if an SMBP program would add value and help you be something that would be a valuable tool for you to be able to manage your patient's blood pressure. So with that, I thank you all very much for your time and attention today. And please do not hesitate to reach out to Tim or myself. While we are located in 2 locations, we have connections across the country to our colleagues, and we can help connect you with those resources in your local AHA staff who can help provide you and dive into this even more. So thank you all very much.